All right, so I'm super excited to be with Dr. Abhinav Jha, who's going to be talking about going from pretty pictures or pictures that are only pretty to pictures that are clinically useful. Super excited about this. Abhinav is associate professor at the Department of Biomedical Engineering and the Mallinckrodt Institute of Radiology at Washington University in St. Louis, and also the evaluation team lead at the SNMI AI task force, which we're going to learn about a lot more. But thank you, Abhinav, for accepting my invitation and being here.
Oh, thank you, Arman, and it's truly a pleasure to be here. And I'm very excited to share this story with you and everyone else who's watching this video. As you know, I have been a huge proponent of task-based image quality evaluation. That is, images developed using AI algorithms and other algorithms should be valid based on clinical tasks. But the story I want to share with you today relates to not just their evaluation, but how can we bring the clinical task into the development process.
So let's get to it. Let's get to it. So what's the main theme that you're going to talk about today?
Oh yeah, so we're going to talk about AI for medical imaging and how do we make it trustworthy. For example, let's say we use AI for things like denoising, like reducing the radiation dose that's required medical. It's a very significant application. But then we develop these denoising algorithms and we use them and we get these good looking images. So then we need to ask the question, are these images just pretty or are they clinically useful? And if they are not, then what do we do to make them clinically useful? And that's the story that I'm going to share with you today, the story that actually occurred very much in my own lab.
So I've seen, Abhinav, a lot that AI and specifically deep learning can really trick us. Like there's been a lot of, and even machine learning in general. Sometimes you discover things, you do some predictive model, and you see that it works super great, and then later somebody else tries your model and it doesn't work. So sometimes AI can really trick us, and we think we're doing such a great job. And I think you're covering it an interesting angle into it. That sometimes we look at the images and they look great, but I think you have been raising alerts and concerns about this, that just if an image simply looks great, that doesn't mean it's actually any good.
Yeah, I mean, I think I heard a talk actually that I would like to share here, from one of our organized AI summits where the speaker made a very good point about how AI can fool us. And it's very important to protect ourselves from because the AI algorithm outputs often look that good that it's very easy for us to be fooled.
Yeah.
But what I want to share today is not just those concerns, but how we can learn from those concerns, how we can sort of learn from the knowledge that we gain when we start analyzing things at a much deeper level on why AI is actually giving an output and how we can then use AI to actually improve performance on clinical tasks.
So two very important topics. So let's get to it. So number one is, are they useful? And number two is, if not, how can we make them useful? Okay.
Yes, exactly. So with that, just like to give a brief overview of my own research so that my own background becomes clear and provides some of the context for my own thought process. So the mission of my lab is to develop clinical task-specific computational imaging solutions for improving the diagnosis and treatment of diseases. And I want to emphasize the word here, clinical task-specific. That is when we are developing a new solution, and this could be an AI-based solution. What is important is that it perform well on certain clinical tasks. And you will see that theme throughout this discussion that we are having today, which I'm really excited to have. There's special focus in our lab on nuclear medicine. So we develop a lot of PET and SPECT imaging solutions, and we work on different areas in this domain, ranging all the way from image reconstruction, image enhancement, image analysis, as well as image quality evaluation. And for this purpose, we develop physics-based methods, we develop AI-based methods. So we have many tools in our toolbox, and we have wonderful trainees in the lab who actually develop, generate, execute all of these ideas that we have. And I've been very fortunate to be able to have such wonderful trainees.
So Abhinav, yes, take us please through the specific modality you're gonna show results for. But of course, what's very interesting about your work is that this paradigm that you talk about is applicable to a broad range of applications and medical imaging applications. But of course, at the end of the day, we need to be evaluating for specific tasks and modalities to see how AI is doing. So I kind of like the fact that it's broadly applicable to many different applications, but you're going to focus on a very specific application. So what is that application?
Yes, indeed, Arman. Thanks for highlighting that. Actually, as we think about validation or even development of AI for clinical tasks, it's important to sort of hone down on the clinical problem and understand that clinical problem. And so in this slide, what I would like to talk about is the modality that we work on. What is the specific clinical task that we are after would be the topic of the next slide. So what we are going to work on is this modality called cardiac SPECT, or myocardial perfusion SPECT more specifically. So what happens in this imaging modality is there's a patient who comes in with symptoms of coronary artery disease. Now, here I want to highlight that coronary artery disease is indeed one of the single largest cause of death worldwide. And cardiac SPECT has a very important and well-validated role in the diagnosis of this disease. And I'll talk about that in a little while, but let me just tell you about the clinical workflow here. So the patient comes in with symptoms of coronary artery disease, and oftentimes what happens is that the physician recommends that they actually undergo a SPECT scan. What happens in the SPECT scan essentially is that the patient is given some radio tracer that goes and it's observed by different regions of the body, and then it emits photons. So what happens is that if there's a region in the heart that's not healthy, then there's less uptake of tracer in that region. And I'm just giving a very lay overview, so I apologize to all the physicians who are listening to this. But the SPECT scanner then detects these photons that get emitted, and then it creates these images. So these are all the left ventricle. What you're seeing here in the shape of sort of a donut is all those left ventricle images that are there. And just like want to emphasize here that this is a established, well-validated, widely used and modality for diagnosing coronary artery disease. And in fact, I have read numbers like around 8 million to 9 million scans in the US alone are done using these cardiac SPECT procedures. So what is the specific clinical task here? So let's go a little bit into what happens. So now, we have coronary artery disease. In this disease, what happens is that your coronary arteries get blocked due to plaque formation. This happens due to various reasons, such as genetic, but also, all the junk food that we eat, actually, it goes and sort of settles in there. And so as a result of that, there is, the blockage of the coronary arteries. And if the coronary arteries are not able to supply blood, then what happens? The heart muscle gets damaged. And so there is area of reduced blood flow. So what you're seeing here is sort of the heart muscle. And you see this region here where there is reduced blood flow. And this is the major clinical task when we do these cardiac SPECT studies. So for the physicians, look at these and say, is there a defect present? Or if not, then that's good. Then you can send back the patient home. But if the defect is present, then depending upon the extent and the severity of the defect, you may actually make a clinical decision of which could be over a range, really.
Where in cancer, we're looking at lesion detection, hot uptake. Here, we're looking at sort of a cold region and a relatively cold region, defect detection, right? So how do we evaluate how a certain image, how useful a certain kind of medical image is, for example, in this application?
Yeah, that's a great question, Arman. So how do we evaluate performance on, let us say, the task of detecting defects? And you mentioned about cancers, and there we have a task of detecting tumors, and here the task is of detecting defects. So how do we go about doing that? So what we could do is we could say, hey, there's an AI algorithm, and what do I want to do? I want to be able to both be able to detect a defect if it is present, which is called as true positive. And if the defect is not present, then I want to be able to say, oh, there's no defect. So I want to have as little false positives and as many true positives as I can. And we need to remember here that, oftentimes these images are actually read by human observers. Not oftentimes, actually, in research, we use these things called mathematical observers, but in the clinic, actually, human observers are the ones who are reading these images. These are trained physicians. So the way to evaluate these algorithms is that we have a human observer, or in some case, a mathematical observer that has been shown in other studies to emulate human observer performance. And then we look at the sensitivity and the specificity of these observers. And with that, we plot what is called a receiver operating characteristics, or an ROC analysis plot, ROC plot. And from the ROC plot, basically, you can see this plot here. What we like is to have very high true positives and very low false positives. And then the area under this ROC plot, also called as the AUC, or the area under the ROC curve, gives us a measure of how good we are doing on the task of defect detection. So as you can see, there's a very comprehensive way to evaluate performance on the task of defect detection.
The area under curve is 0.5. It's almost like a random guess. If it's a 1, it means you're doing a perfect job of it. And often the performance of any image generating algorithm is somewhere between 0.5 and 1. Right?
Yeah, and so indeed what you would like is for this curve to be as closer or as higher as possible. And this is an important point, as we will see in the coming slide. And what you like is to have an AUC value that's closer to 1 again.
Right.
So with that, I didn't mention this at the beginning, but the way I have structured this is actually as a roller coaster ride. So one of my favorite rides in the Six Flags, I don't know if you have been to Six Flags, was this ride called Goliath, where what happens is that you actually go all the way up and then you fall down into a tunnel. And when we were doing this research project, we actually felt like we were on one of these roller coaster rides because there was all these highs and lows. And that's the story that I want to share with you today is how did we take this roller coaster ride. I hope I can share this excitement, and hopefully you also feel, and you and others who are watching this also feel. So with that, I'd say tie your seat belts and get ready for the ride, with the background material being ready, and we have gotten our tickets. So here we go. So here's the problem. Cardiac SPECT procedures require patients to be administered substantial radiation dose, and this can be as high as 48 millicurie, and to be scanned on the scanner for a pretty long time. Actually, it could be 15 to 20 minutes. So, and these are both challenges, right? We want to reduce radiation dose in patients. And of course, we want to reduce the acquisition time because patients can move, and it's really not very comfortable for patients to be stationary for that much amount of time. And if they move, then there is all these motion artifacts. So there is an important need to reduce radiation dose and acquisition time for patients. But when you reduce this radiation dose or acquisition time, remember that you are now getting lesser photons to prepare your image. So that impacts image quality. So let me show you an example here. Here is a patient, and you have a low normal dose image here, and you can see that there's a certain defect that's present here. What happens when you actually get the low dose image? So you can see that this particular defect here has become much wider. And now 2 new false defects have also gotten created when you get this low dose image.
Degrade your the AUC performance because you're having more false defect detections. Yeah.
And I'm not a physician, but this can have huge clinical ramifications actually. As you can see here in the normal dose image, a physician may think, oh, it's a mild defect. But in the other case, it may be like the physician may say, oh, no, you need to go to a cath right now.
Yep.
A catheterization because you have a serious defect in there.
So in cancer imaging, similar thing obviously happens, as you know very well. As you generate images that are noisier, you suddenly may see you discover a lot more findings that are actually not real, so a lot more false positives. So that's the problem with having noisier images.
Yes, indeed. Actually, noisier images can easily lead to increased false positives, and we would like to avoid that as much as possible. So if we could develop solutions that could build upon maybe the things that we see in deep learning,
yep,
that would still reduce radiation dose, but give us images that are good quality, and quality here being defined in terms of measure on clinical tasks, that would be fantastic, right? And that was the start of our ride.
So I think everybody thinks of deep learning as some kind of magic. So why don't we just apply this magic box and just get images that are better? And so you're injecting less into patients, and the qualities are as good as injecting the same amount or high amounts, and we can all be happy. Kind of.
Yes, indeed. And that would be highly significant, right? If we could do that, because we would be able to reduce the radiation dose as well as the acquisition time. And so let's go back 5 years from now. Yeah, 2019, we tried asking the question, could deep learning help? Because at that point of time, deep learning was actually helping especially in the computer vision community, towards sort of denoising these images. And I'm just showing you a couple of examples here, but you can look at the images on the left. They look really noisy. You can see this image here and see this image here. But with deep learning, we're actually able to get very, very good looking images actually. So we were like, if it was showing so strong performance in denoising all these natural images, could it help in denoising medical images? And that led to our initial efforts. on developing a deep learning based denoising technique. So we start off with exploring a commonly used deep denoising technique. This work actually was led by one of the PhD students in my lab, Zitong Yu. So the idea was, okay, let's take in a low dose image, and I'm not going to do technical details here, but we developed a deep learning algorithm. It was a CNN, it was a encoder decoder based approach, and this algorithm minimized the mean square error between the normal dose and the predicted normal dose images. So essentially, the idea is, okay, let us predict something that has sort of as an error metric from the actual normal dose image, it is actually pretty low, right? So you're trying to minimize that mean square error. It's very commonly used deep learning based procedure for denoising, because if you can denoise, you can sort of reduce the mean square error, the images actually start looking much better. So let us see what we observed here.
Supervised AI, supervised deep learning, and you're using the reference truth, the normal dose images, and you're trying to bring the low dose images as close as possible to the reference images. Yeah.
Yes, indeed. So here I'm just showing here. So here's a normal dose cytogram, and here's your low dose cyanogram, right? And you can see this cyanograms, of course, are representations of the projections, the raw data that we collect with these SPECT scans. And so what we are seeing here is that you see this image looks much more noisier, and we reconstruct these both using sort of pure physics-based approaches. So we get our normal dose image, and you can see the myocard, the left ventricle wall here, and you can see the low dose image. And I hope that it's clear that you can see so much of noisy effects down here. And so what we did was that we had the CNN-based denoiser, which, as you mentioned, basically the idea was, let's train it to make normal dose image or synthesize normal dose images. And when we took our trained CNN-based denoiser, we took our low dose image, pass it through the CNN-based denoiser, we got a pretty impressive looking low dose CNN denoised image. In fact, looks less noisy. And one of my collaborators made the point, actually, not only does it look as good, probably looks even better than a normal dose image, because it's even less noisy. And we then were like, okay, visually things look good, so let's do a more quantitative evaluation. So we looked at evaluation using these metrics called root mean square error and structural similarity index and peak signal to noise ratio. And these are metrics that are conventionally used to evaluate a lot of AI-based image processing techniques. And the inference as per all of these metrics was that AI is better. And it's very statistically significant. As you can see, we got p-values less than 0.01 in all the cases. So we were like, okay, this is great. We are on top of our roller coaster ride. We can reduce radiation dose by 10 times. We're really excited about this finding.
And papers get published relatively, you could say easily. You're reporting, mean squared error, MSC, you're doing PSNR, you're doing SSIM, all these metrics, and everything looks better. Papers are being published, and we're all good. And then what happens?
And then, like I said, this Goliath ride, right? I'm on top of this roller coaster. These things look great. And then I tell Zitong, can you just go ahead and do the evaluation on clinical task? And I'm really looking forward to what he finds out. So we did what is called a model observer study. So we had a anthropomorphic model observer. And this observers, has been shown in previous studies to emulate performance on as human observers. So this observer had to do the defect detection task. Remember, I talked about earlier, right? So these images are required for detecting cardiac defects. We said, can you detect defects and tell us how good you look? So how do you evaluate performance? Again, remember ROC analysis. So let's look at the ROC plots.
Yep.
And now, what we observed was not just surprising, but actually alarming. Because what we are seeing here, here's your normal dose ROC plot up there. And here's a low dose ROC plot down here. What we observed was that the AI-based approach
does not
absolutely zero improvement in terms of the task of defect detection. In terms of the clinical task for which this image is acquired, there was actually no improvement.
I remember attending a Society of Medical Medicine conference, SNMMI meeting in 2020, and I saw these results. And the truth is, you had mentally prepared me for this. So I was not shocked when I saw this, because you had prepared me, but it is very surprising, I would say. I mean, the truth is, majority of studies don't even do this kind of evaluation, and that's point number one. Of course, point number two, I think you're going to talk about, is how do we fix this problem? But the point is that we need to recognize that the performance, even though the images look better, the performance may not be better at all.
Yes, indeed. As we look at deep learning and for denoising, then it's very important that we, in my opinion, look at performance on actual clinical tasks. So while the metrics like PSNR and RMSE, they may show promise. I think it's in order to see whether the promise actually is clinically valuable and useful. I think ROC analysis studies are very needed. This is not to say that those other works are not important. They are equally important, and as we advance in the deep learning field, but it's also very important to be able to look at all these ROC analysis studies towards clinical evaluation. So let's see what happened with the AUC. And as you may expect by now, what we observed was that AI was giving same performance as normal dose. So there was actually no improvement in performance. And then we started looking at the images. I showed the images. The images look pretty good. What happened? And so what we are observing here is that in several cases, actually, AI was sort of washing out the defect.
Yeah.
In other cases, it was actually creating defects when there was none that's present. So even though the deep denoising algorithm was actually creating these pretty beautiful looking images, the images were actually not useful.
They were not more useful than
a low dose image.
Nothing.
Than a low dose. Thank you. Yeah, indeed.
Yeah.
And then, these findings were also observed in other medical imaging modalities. Actually, work done at the FDA, as well as by other groups, showed that, in case of CT, in case of digital breast tomosynthesis, we are observing that denoising was washing out the small, low contrast signals, as we see in this application here. And there was other work also that showed that, PSNR and RMSE may actually not correlate with performance on the clinical task.
Right. So, PSNR, SSIM, all these things may look better, but they will not correlate with the fact that the performances are not getting better. Yeah.
Yeah. And so there's an important need for task-based evaluation. And so we got these findings. I remember this was December of 2019. And I was like, oh, these findings are very important. And so let us put this. SNMI had a deadline of January 2020. And as you know, it's always after the new year, which is great. So I said, Zito, let's put an abstract on this topic. And we did. But I was not sure what the reception of the community would be to this particular finding. The community actually received this finding very well, I must say. And then, in fact, I got asked after that to be part of the SNMI AI task force and actually lead the evaluation team of the task force that recommended these Reliance guidelines.
I'm so happy this happened. So the AI task force itself was put together in 2020. So there were multiple teams in it, and I'm so happy that you were leading the team that was doing the developing best practice guidelines for evaluation. And of course, that led to these Reliance guidelines, which are now becoming part of the Journal of Nuclear Medicine recommendations for papers that are being submitted. So that's been pretty great. So take us through this pyramid that developed.
This pyramid, actually, what we are seeing here is that as we develop AI algorithms, we need to be mindful of the objective that we are planning to achieve. So we can have our initial proof of concept validation studies. Let's say that we are developing a denoising algorithm. Then in the proof of concept study, we may say, oh, well, how well does it perform on RMSE and SSIM? But then when we look at task-specific evaluation, we should look at things like ROC analysis. Or if you're looking at quantification tasks, then how well does it perform in terms of accuracy and precision? And then we start getting the big guns out, right? How well does it perform actually clinically? Then we need to look at performances of this algorithm on diagnosing diseases. For example, in this case, it would be how well does this algorithm help in the diagnosis of coronary artery disease and not just defect detection. And then finally, of course, when these algorithms get deployed in the clinic, we come up with this post-deployment strategy. And I love this pyramid. As we know, we had multiple discussions within our task force on what would be the right structure for sort of bringing together this framework. And we discussed about arches, pyramids, several other architectural structures that we talked about. I just want to also say at this point that it has been a total, very rewarding and very educational experience for me to be part of this task force. Loved working with people across multiple backgrounds, including nuclear physicists, physicians, statisticians, representatives from the industry, as well as from regulatory agencies. I think it was a great experience for me.
I think this was a great effort with your leadership, and I think back then it was not obvious to many people that this should even be done. And I remember once we were in this meeting and a vendor showed up and they were saying, oh, we're, for example, denoising images, and literally their evidence was that the images looked better, and that was it. And we're all surprised back then, but today I think that would be considered totally unacceptable. So going up this pyramid, I guess for segmentation, example of proof of concept would be like a DICE score assessment. And as you move up for technical task specific, it would be more like, what is the performance
MTV
analysis? And moving up, it would be more like, can we predict outcome of patients better? Something like that, right? So
yes, indeed. And here I'd like to also mention to you that segmentation algorithms, if they are evaluated using DICE score, may actually not give the same interpretation as when evaluated on clinical tasks. This was a paper that we recently published in Journal of Nuclear Medicine in January, where we showed that segmentation algorithms, including those based on deep learning, may provide you with different interpretations based on what you obtain with DICE scores versus what you obtain on the task of estimating metabolic tumor volume. This was in the context of oncological PET images, of course.
So it's fascinating to see this is happening. I guess the question is, why is this happening?
Yeah, indeed, Arman. That leads into my next slide, actually. Why are we seeing this limited performance? I mean, clearly the AI algorithm was denoising images, right? So we saw this happen. So the question was that we know that, if we are able to reduce the noise in the image, then it should generally help improve observer performance. So we started asking this question. We started going deeper into this. And one of the things, this sort of goes back to my training, which I had good fortune of having with Dr. Matt Kopinski and Dr. Harry Barrett, on how do we uh, develop observers that can emulate human observer performance. And there's some seminal work that had happened by Dr. Kyle Myers on sort of channel mechanisms and things that went in further. Dr. Eric Fry, Dr. Michael King, they worked on channelized Hotelling observers. So basically, using psychophysical studies, it has been shown that human visual system can be modeled as processing images through frequency selective channels. This is an area that you also have explored, Arman. And so I started looking at this question that, okay.
If I may say something, basically, I remember in my years when I was at Johns Hopkins, I was exposed to, because there are folks there that were also influenced by this school of thought, I guess coming from Arizona, Harry Barrett and the people that were in that circle, the mindset that we shouldn't be just looking at, conventional metrics. And I think you have a whole other talk for us in the YouTube channel about, task-based image assessment, etc., some of those things. But the point is that this was a realization decades ago by that school of thought that we should be looking at these things and coming up with metrics, even though they may be complicated metrics, but metrics that better emulate the human eye and human performance. So I guess that's what you're talking about.
Yes, indeed, actually. And with regard to this, there has been, I mentioned a few people, but there has really been a lot of researchers who have contributed to this school of thought.
Yeah.
That will take up the entire, I think, time of the discussion. But I also want to emphasize that given this progress, it has become easier and easier to be able to sort of use these tools.
Yeah.
So essentially, the thought was, well, like I said, like I mentioned, using psychophysical studies, it has been shown that the human visual system can be modeled as processing images through these frequency selective channels here. So here I'm showing you sort of these channels, and it's like, these are the frequencies that get selected. And so in some sense, you take your image and you get these features that are the outputs of these frequency channels. And this sort of gives you a channel vector.
Mm-hmm.
So we asked the question, well, what is the impact on these channel vectors due to the denoising operation? So it was a very interesting eigenanalysis based approach, and I will not be going into the details of that. I'll try to provide some intuition. I welcome for the audience to look at our medical physics paper that I'll mention towards the end. But just to give you some insight here. So let's look at these images here, right? And here is a defect. Now, as the severity or the contrast of the defect is high, it's sort of easy to see this defect here. But as the contrast of the defect sort of lowers, it becomes harder and harder to see the defect, right? So as the defect severity decreases, it becomes harder to detect the defect, right? That makes sense.
Yes,
And so performance of the human observer is directly proportional to the defect intensity, as per that model observer formalism.
show that. You can show that in you know, I mean, it's intuitively what you say makes sense, but I think in your paper you kind of talk
Yeah.
about it.
And so essentially what I'm trying to give you here is sort of a very intuitive feel for what that model observer is about. It's a mathematical observer that contains these terms, one of which is the defect severity, and the other one is the how noisy the image looks like. So again, here you see an image that's less noisy. You can see it's pretty smooth, right? And you see the defect in here, and it's sort of easy to see the defect. But as I make the image look more and more noisy, now you're here and you're like, okay, is this a defect? Is this a defect? So there are all these regions, and you're like, which of these is defect, right? So as the images become more and more noisy, it becomes again harder and harder to see the defect. So the performance sort of inversely proportional to all this background noise that I have. And so what this model observer does in a very, I have just given you intuition here, but in a very theoretically elegant way, it is able to summarize the performance of the human observer using this defect severities and the background noise. And what we observed using an eigenanalysis based approach on that particular, on this particular impact on defect extent, defect severity and the impact on the covariance noise was that while denoising was making our images look less noisy, as you can see here, here's a normal dose image, there's a low dose looks noisy, and here is your deep learning denoised, does look less noisy. What it was also doing was actually reducing the defect contrast. So you may have a defect here, and that defect contrast really goes away. So while it's doing well on reducing noise, it's actually reducing the defect contrast. And so what we observe is there is no overall improvement in observer performance. And this was an eigenanalysis based approach. Again, I've tried to give an intuition here, but the details of that are available in this particular paper. And this paper, I'm happy to share, actually got a lot of media attention, actually, where I was very happy to see that there were several folks.
I mean, it's for a number of people, it's been like this light bulb saying, "Whoa, wait a minute! I mean, AI is not as easy or powerful as we thought, and we should be very careful about it, right?" Which of course brings up the question: should we just give up on AI and it's just not doing anything useful, and should we just move back to the old days?
Yeah, and it's a very good point, actually. I always felt somewhere deep inside that with AI, we are able to learn things or encode things in ways that may not be possible, right? I mean, we have a large population of images, and definitely there is information that we can obtain from this large population of images. So I was talking about a Goliath ride, right? And in that ride, we go through a tunnel. So I was like, is there light at the end of this tunnel? Does this mean deep learning cannot help reduce radiation dose, or can we potentially advance deep learning to help? Can we use AI in a sort of a smarter way, in a different way, such that it is actually able to still improve performance on the clinical task? And here I want to just mention, that's why I think the clinical task is important. So when we think about the clinical task, you're like, okay, how do I improve performance on that particular task? And so then I'm like, can I actually have that task built within the algorithm? And this was our foray into trying to do that. And here I'd like to give a shout out, Armand, to your group as well. You have been looking at something similar for image segmentation. As I recall, in your group, Farishte has been looking at something on how do we sort of encode the task of quantification in deep learning. And I've been very happy to collaborate with your group on that. And so here it was like, here a detection task. How are we going to incorporate the detection task into our deep learning algorithm? So to do that,
thinking, right? It's like, let's not take. I mean, I think it's already a major paradigm shift to simply say, look, let's do careful evaluations. Maybe there are algorithms out there that actually do perform better compared to at least other ones. So that's in itself is an accomplishment. But I think more actively, instead of just evaluating better, the question is, can we actually make the algorithms perform better? And so let's see what you're gonna teach us.
That's what made this very exciting for us. Like, how do we actually bring in the task into the algorithm development and not as an afterthought, if I may, right? How do we bring in the task into the development of the algorithm? So let's go back to that initial slide I showed you earlier, where we have an image and then you have this frequency selective learners, which are outputting all these channel features, right? So can we design a deep learning algorithm that, while performing denoising, also ensures that these features that are used by the human observers are actually preserved? So go ahead, do your denoising business, but don't wash out the defect. Ensure that those features which are used by the observers are actually being preserved.
Mhm.
Towards that goal, we developed a detection task specific denoising method. We call this method as demist. It sort of demystifies the image. You have noisy image and you're sort of demystifying it. But the idea was that, you demystify it in a way that the defect actually sort of shows up better.
I remember seeing this work in SPI meeting, medical imaging, in 2023 in San Diego, and great thinking, right? So you're modifying the loss function. So how are you exactly doing that?
Yeah, and thanks for bringing up the SPI medical imaging. This work was led by Ashikur Rahman, who was then a student in my lab and has since graduated. And he was this work was actually an honorable mention as a poster at the SPI meeting. So we thought, okay, our typical deep learning based loss function that we had shown previously, it had what is called a fidelity loss term, which minimizes the mean square error between the normal dose and the predicted normal dose image. So here is your fidelity loss right here.
Usual.
Yeah, that's or visually the image looks good. We said, can we actually incorporate an observer loss? And what this term does is it preserves feature that assist in the detection task. So can we minimize the mean square error between the channel features that I talked about, between the normal and the predicted normal dose image? And if we could do that, then the thought was maybe, we'll sort of denoise the image, but we will be preserving those specific features that are needed to perform the detection task. And maybe we can get the best of both worlds.
Because of what you said before, these channelized sort of assessments, channelized hoteling observer relies on the fact that, the human visual system correlates with a technique that essentially creates these channels and analyzes images. So if you do better matching in the channelized space or the frequency space, you'll hopefully do better in detection tasks.
Yes, indeed.
Okay.
And so with that, sorry,
performance. What happened when you did this?
Yeah, so let me share that actually. So what we did was that we developed this method and we said, let's do a very rigorous retrospective evaluation with this method. For this, we actually collaborated with Dr. Barry Siegel, who's in the nuclear medicine, very senior physician. We had a great pleasure of collaborating with him, as well as work with Dr. Richard LaForest, who is a clinical physicist here at WashU. And I want to sort of mention this here that I think AI really is multidisciplinary. So it's great to be able to collaborate with physicians and physicists and biostatisticians and other folks in order to be able to do these evaluations in a very rigorous manner. And so again, we are blessed to be at WashU. We have access to large amounts of clinical data. And as we did the pre-processing of the data, we ended up with around 338 cases. Now we had to pick up normal cases because in these images, we did not exactly know what the ground truth was. So what we did was we inserted sort of defects. We inserted a wide range of defects at different locations and with different extents and different severities. These data were obtained for both male and female patients, as well as data was obtained from different scanners.
Right.
And so this was our methodology to perform the observer study. So we had a normal dose image and we had a low dose image, both of which were fed to this anthropomorphic model observer that in previous studies has been shown to emulate human observer performance. And we also took our low dose images and sent that through our demist approach. And again, sent this through a model observer. And for comparison's sake, we also compared our performance with a task agnostic deep learning based denoising approach. This is very similar to what I had shown previously. This is the one that only has the fidelity loss, does not have the observer loss. So I call it task agnostic because it was not really focusing on the detection task.
So doing nothing, doing conventional denoising, and doing sort of a task aware denoising. So 3 techniques. So what did you find out?
Yeah, so we looked at the AUC values, and what we observed was very happy to share here.
Yeah.
We looked at this at different dose levels, 6.25% low dose all the way to 25% low dose. And what we observed was that there was significant improvement in performance that was obtained using our DMIST approach. Right? So in all these low dose level cases, we are observing a significant improvement in performance. I do like to highlight here that we are still not there. Here's your normal dose image. So there's more work that needs to be done, but we are getting there, I think. Uh, it's very interesting, this whole paradigm, trying to understand how much information is there and what we can extract and how we can benefit from AI. But what we observed as a conclusion was DMIST significantly improved performance on defect detection tasks compared to low dose as well as the task agnostic deep learning method. And not only was this observed over the entire population, but across different sexes, both male and female patients, across different scanners. So these are two different scanners that actually have different detectors. One of them is sodium iodide, the other one is CCT. And then also across different defect extents and severities. And this is very important because in the patient population, you may actually observe different amounts of extent and severity. So it's very important to assess whether the method performs well across these. In other words, how generalizable is the method? And we found that our method was pretty generalizable in the studies that we did. Now, let me show you some qualitative evaluation results here. So you can see these normal dose images. I'm showing you here 4 examples, all of which actually have a defect in the normal dose setting. What we observe is that the task agnostic deep learning method sort of washes out the defect. Remember, I talked about this earlier as well, right? But you can see it here, you can see it here, it's sort of washing out the defect. But our DMIST approach, it denoises the image, but it does not wash out the defect. The defect is still there. And one example that I would specifically like to highlight, this bottom right example here, you see the normal dose image, small defect. Look at the low dose image, it's very noisy, right? You can, this would be like, could be perceived as an additional defect.
Multiple false defects, that's right.
Yeah. Right, multiple false defects. And our DMIST approach sort of denoises the image, and now it doesn't look like this. So much lower false defects. So what we observed was that the task agnostic method tends to wash out the defect, but the proposed method was able to preserve the defect features, even though it sort of denoised the image.
That's very impressive. Yep.
So here's the public. This is very recent stuff. It actually just got published recently in a special issue in IEEE Transactions on Radiation Plasma Medical Sciences. And happy to share it has been getting attention in the media as well. So the takeaway point I'd like to say is that for AI-based algorithms to have an impact on medical imaging, going back to our original theme, right? They need to be designed and evaluated for clinical tasks. Being pretty is not sufficient. It needs to be clinically useful. But AI can provide a mechanism for that. Integrating concepts in AI and task-based image quality evaluation can actually help us achieve that goal. Okay. So, of course, this is, this work requires the limitations with the studies and requires much more future work. The proposed method was evaluated with model observers. And so human observer studies are needed. And for this purpose, we have developed interfaces through which these human observer studies can be conducted. We have a web-based app that actually is widely accessible. Everyone in the community can sort of use these apps so that they can do their own human observer studies, both ratings scale studies I'm showing here, but also 2 AFC studies. And your group, Arman, has also been using these apps, and I hope that you have found them helpful.
Absolutely, and I think these allow us to produce algorithms or propose use of algorithms that produce images that are more acceptable ultimately for radiologists, so that a naive work might have said, look, we can reduce the dose to 6% of what it was, or 5% or 10%, and we're going to get as great an images as the original image. But of course, your work shows that that's not true, and so then people would be experimenting with more modest dose reductions that are going to allow us to get definitely closer to the original sort of images. So I think that allows a better believability by clinicians of the efforts by our community to develop AI algorithms.
Indeed, and this is the second limitation, as I mentioned here. The performance is still lower compared to normal dose images, but what we can do is identify the low dose images where improvement compared to low dose actually translates to equivalent performance as, or at least non-inferior performance as normal dose images. With that, I'd like to conclude by saying that AI algorithms plus clinical task-based evaluation can help transform medical imaging. And I'd like to acknowledge many people. This has really been a collaborative effort here. I'm only showing my collaborators within WashU, but I've had the good fortune of collaborating with folks outside WashU within the SNMI AI task force. I've had multiple discussions with many of the task force members along with yourself. And this has really helped me enrich my own thought process. So very grateful for that. I'm also thankful to all the members of my lab who are able to develop and execute and move these ideas forward. And of course, would like to thank the funding agencies, uh, more specifically NIBIB that funded this award, but also the National Science Foundation, which has funded some of our research, and the SNMI, which has funded us through student research grants. So with that, Arman,
Thank you very much, Abhinav. This was outstanding. And I think you've been, and your lab has been doing just amazing work in the past number of years. And I'm so happy you accepted the invitation. And thank you for sharing your thoughts and your work with us.
thank you, Arman, once again for this invitation. It's been a true pleasure talking to you and discussing the story. And I hope that we went through the roller coaster ride together, and I hope it was an enjoyable ride. If you have any questions to the audience, I have provided my email ID here, so please feel free to email me with any questions that you may have.
Thank you very much, Abhinav.